At the outset, I'd like to thank the College of Ophthalmologists for providing this opportunity to talk to you on referral to the neurologist, what and when. As you know, the ophthalmologist would often refer patients to the neurologists, and the conditions can have a broad variety and spectrum. However, the conditions can be uh, broadly categorized into visual disturbances, which are neurological origin, and eye movement abnormalities. Uh, these are the common referrals that one would need when faced with a patient with visual disturbance. A patient might have a visual field defect, which might be sudden or chronic or progressive, or they may have unexplained visual loss, which involves part of the visual field, which may indicate stroke, brain tumor, or even optic nerve pathology. Uh, for example, a patient might have a junctional scotoma, which in which there is monocular visual loss involving the ipsilateral side, and on the contralateral side there might be a superior quadrant anopia involving the temporal quadrant. This might suggest that there might be a lesion in the close to the chiasm between the junction of the optic nerve and the chiasm. The patient might have bitemporal hemianopia, which might suggest chiasmal involvement, or a congruous homonymous hemianopia, which might suggest optic tract involvement, or a quadrant anopia, which might suggest optic radiation involvement, as well as a homonymous hemianopia with macular sparing, which might suggest the occipital pole to be involved. So as you can see, the visual field defects can be quite broad. Patients might present with double vision, which is binocular, which requires neurology input. They may have persistent double vision, especially associated with neurological signs such as ptosis, which could indicate either a cranial nerve pathology or even a neuromuscular junction disorder such as myasthenia. Some of the patients who do have these pathologies might have subtle signs where oculomotor movements might seemingly be normal. In such instances, the cover-uncover test, as well as the alternating cover test, might be useful in assessing both trophias as well as tropias. Transient visual loss often requires neurology input. Often the pathology or the process of visual loss involves the central retinal or branch retinal artery, and in such instances, these patients would require urgent input from the neurologist, as these patients are at higher risk of developing stroke in the future, in the immediate future. Visual hallucinations, again, it's a spectrum of pathologies that can present with visual disturbances or visual hallucinations. For example, occipital lobe pathologies, such as focal onset epilepsies involving the occipital lobe, can present with visual hallucinations. Mainly the seizures that originate from the visual association cortices. the visual hallucinations can be a result of neurodegenerative disorders such as atypical Parkinson's disease, like diffuse Lewy body dementia. Um, Very rarely there can be visual hallucinations due to damage to the peduncle of the midbrain, which is known as peduncular hallucinosis. And also, when a patient is completely blind, they may have visual hallucinations as well, which is known as a Charles Bonnet syndrome. So as you can see, there's a wide spectrum of visual hallucinations which might require neurology input. Eye movement abnormalities require uh, the referral to a neurologist. For example, nystagmus, which is an involuntary repetitive eye movement, which might suggest uh, the vestibulocular system to be involved. Nystagmus is generally uh, either pendular, which are sinusoidal oscillations, which do not have a fast or slow phase. There can be nystagmus could be jerk nystagmus, which basically could be uh, based on the direction of nystagmus, can be horizontal, vertical, or torsional, or what we mean, or rotational. Um, and it's important for the neurologist to differentiate peripheral versus central causes from nystagmus in their evaluation. Ophthalmoplegia, again, is an indication for neurology referral, paralysis or weakness of the extraocular muscles, which might indicate either single or multiple cranial nerve palsies. Could also indicate myopathies, neuromuscular junction disorders, as well as brainstem involvement as well. Abnormal pupillary responses often require neurology opinion. Unequal pupils, so it's not only the abnormal pupillary response. Unequal pupils are also an indication. So, for example, conditions where direct light reflex is absent and the indirect light reflex is present may suggest an anterior pathway involvement of the optic or the visual pathway. The patients could have Argyll-Robertson pupils, for example, where there is near light dissociation, where the light reflex is absent or poor, and the accommodation reflex is preserved, which might suggest either a midbrain lesion or at times pathologies which involve the midbrain, such as syphilis, typical or stereotypical examples for such a pupil. So, as you can see, the abnormal pupillary responses are an indication for referral to a neurologist. Patients can have systemic neurological symptoms which require again opinion from the neurologist. For example, headaches with visual symptoms. Severe headaches can be accompanied by visual symptoms such as aura or visual loss. And often these patients, 80% of the time, or 8 or 9 times out of 10, they would have migraines, which require long-term follow-up by the neurologist. The patients might have features of raised intracranial pressure. They might have epiedema associated with the headaches, and therefore these patients require urgent evaluation at a neurology unit. Furthermore, neurological signs such as weakness, speech difficulties, sensory changes alongside visual symptoms are other um, indications for a neurology opinion. Chronic or progressive conditions such as optic neuritis, which involves recurring inflammation of the optic nerve, may be associated with uh, a variety of demyelinating causes such as multiple sclerosis, MOG-associated demyelinating syndrome, and NMOSD, or neuromyelitis optica spectrum disorder. Papilledema, again, is an absolute indication for a referral, which means a chronic papilledema, of course. Neurodegenerative disorders such as Parkinson's disease might present with certain visual symptoms. An example would be an atypical Parkinson syndromes such as progressive supranuclear gaze palsy might present with vertical gaze palsy, which um, affects down gaze. Acute visual loss, especially if it's accompanied by other stroke symptoms, needs urgent referral to the neurologist. And of course, other acute pathologies such as demyelinating events as a result of multiple sclerosis again requires neurology input. So we've spoken about the what to refer. So when do we really need to refer? So referrals can be immediate, or it could be urgent, or could be routine. So immediate referrals often the indications should be acute or hyperacute visual loss, which may or may not be associated with stroke symptoms, or if the patient comes with features of raised intracranial pressure, then these patients require immediate referral to the neurology units or the neurologist. Urgent referrals, for example, new onset double vision, acute optic neuritis, as well as significant visual field defects, which might suggest new onset stroke. These patients require urgent referral. And routine referrals are for chronic or progressive conditions that require further neurological evaluation and management. So in conclusion, ladies and gentlemen, timing and urgency of the referral depends on the severity and the nature of symptoms. But when in doubt, it is often better to err on the side of caution and refer the patient to a neurologist for comprehensive evaluation. I thank you for your attention.